Have you ever wondered why a patient with a Parkinson disease develops tremor, slow movements, and muscle rigidity? Or why the lesions in different parts of the basal ganglia produces completely different movement disorders? Even more importantly, how do you write this entire topic in your university exam so that the examiner immediately knows that you understood it? In today's video, I will show you exactly how toppers write perfect 10 marks answer on basal ganglia, including neat flow chart, examiner-friendly diagrams, Parkinson disease, and basal ganglia lesions. And don't miss the last few slides because I will show you different hyperkinetic disorders, basal ganglia disorders, and the easiest way to remember the site of lesions, which most MBBS students find confusing. In a university examination, always begin with a proper definition. Never directly start writing functions. A good definition creates an excellent first impression. You can write basal ganglia is subcortical nuclear masses situated in wide core of each cerebral hemisphere. It regulates mainly voluntary motor activity, posture, muscle tone, and automatic movements. Notice something important. I have highlighted the keywords. These keywords fetch the marks. If you remember only one sentence, remember this definition. It is frequently asked in theory as well as in viva. Now let's see which nuclei actually form the basal ganglia. That is the components. It mainly consists of corpus striatum, subthalamic nucleus, substantia nigra. This corpus striatum mainly consists of caudate nucleus and lenticular nucleus. Remember, basal ganglia act as an important coordinating center of extrapyramidal system. Now the most commonly asked diagram in university examinations. Instead of memorizing randomly, understand the organization. The basal ganglia mainly consists of caudate nucleus, putamen, globus pallidus, subthalamic nucleus, and substantia nigra. Among these, the caudate nucleus and putamen together form the striatum, whereas putamen plus globus pallidus together form the lentiform nucleus. Let's see the essential partners. The subthalamic nucleus. Subthalamic nucleus plays an important role in regulating the movements. Whereas substantia nigra having two parts, pars compacta containing 75% dopaminergic and 25% cholinergic, and pars reticularis which contains mostly GABAergic. Here is a small trick. Imagine the movement begins in the striatum, get processed to the globus pallidus and is modified by substantia nigra, and finally it becomes smooth. This simple sequence helps the student to remember the pathway. Now pause the video for 5 seconds and try naming all the 5 nuclei without looking. You will be surprised how quickly you can memorize them. Now comes the most important diagram of today's chapter. Connections and wiring of basal ganglia. This diagram looks complicated initially, but actually it is very logical. Let's simplify it. First, understand general rule. The striatum is the main input and globus pallidus is the main output. The efferent that is input to the striatum mainly comes from corticostriate, that is from all cortex through glutamate, nigrostriate from substantia nigra pars compacta through dopamine, thalamostriate that is from centromedian nucleus of thalamus, and raphostriate through the serotonin. Now these striatum processes the information, then the signals travel through the globus pallidus and substantia nigra, and finally the information reaches the thalamus. And from thalamus, the corrected signals go back to the motor cortex. So remember this simple flow. First the cortex, then striatum and globus pallidus in basal ganglia, then the thalamus, and again back to the motor cortex. This loop keep repeating continuously while we perform voluntary movements. In university examinations, this flowchart alone can fetch multiple marks because the examiner loves neat presentation. So after understanding the connections, let's see what these nuclei actually do. Now comes the heart of the topic. Instead of memorizing 6 or 7 points, understand one basic principle. Basal ganglia do not produce movement, they regulate the movement. Their functions mainly include 3. First, starting the movement, that is initiation, stopping the movement, that is halting unwanted activity, and regulate the movement, that is smooth out and fine tuning. Imagine basal ganglia as a traffic signal. So it mainly helps in starting the movement, stopping, and regulate. But when this regulation fails, different movement disorders appear. But before diseases, we need to understand the most important physiological mechanism. This is the concept that the student fear the most. But don't worry, I will make it extremely simple. The basal ganglia have major two pathways, direct pathway and the indirect pathway. Remember only one line. Direct pathway facilitate movement, indirect pathway inhibit movement. That's it. Everything else revolves around these two principles. Now let's understand the direct pathway, which is one of the most important university question. Remember one golden line. Direct pathway facilitate movement. Think of it as a go pathway. Let's follow the sequence step by step. The motor cortex excites the striatum through glutamate release. This striatum strongly inhibits the globus pallidus interna through lots of GABA. And because globus pallidus interna is inhibited, it sends less GABA to the thalamus. So the thalamus is disinhibited and it fires glutamate to the motor cortex. And the final movement is motor action. Instead of memorizing arrows, understand the logic. Inhibit the inhibitor and the movement increases. That single principle explains the entire direct pathway. So remember this phrase. Direct is do movements. Both words begins with D. So whenever you see direct pathway, immediately think movement is facilitated. Now pause the video for a moment. Can you explain this pathway in your own words without reading? If yes, you have already understood one of the toughest concepts of physiology. But movement shouldn't always be increased. Sometimes unnecessary movements must be stopped, and that's where the indirect pathway comes into action. Now let's learn the indirect pathway. This pathway works exactly opposite to the direct pathway. Think of it as a stop pathway. Again, don't memorize, understand. The cortex stimulates the striatum, and the striatum inhibits the globus pallidus externa. This globus pallidus externa is turned off, so it stops inhibiting the subthalamic nucleus. So subthalamic nucleus now goes wild, and it says massive glutamate to excite globus pallidus interna. So globus pallidus interna clamp down hard on the thalamus with a lots of GABA, and the cortex receives decreased motor activity. So remember, less stimulation reaches the motor cortex, and final result is reduced movement. So one pathway acts like an accelerator, the other acts like a brake. Remember, the subthalamic nucleus is the key here. It excites the globus pallidus interna, which clamps down hard on the thalamus. Imagine driving a car. So direct pathway acts like an accelerator, whereas indirect pathway acts like a brake. Normal movement occurs only when both work together. In university exams, draw both pathways using different colored arrows. Examiner immediately appreciate well-organized diagrams. But who control these two pathways? Let's see. Here comes the two important neurotransmitters, glutamate and GABA. There are two types of signals, excitatory and inhibitory. Excitatory signals uses glutamate, opens sodium and calcium channels, reaching the threshold, whereas inhibitory signals uses GABA. It opens chloride channels, it hyperpolarizes and freezes the neuron. Remember this rule of thumb we have used in the last few slides. There is green arrow showing the glutamate and red arrow showing the GABA. Let's see the functional neuronal loops or basal ganglia to execute two important functions. Basically, these are primary feedback loop. That is, the information comes from cortex to the basal ganglia, then to the thalamus and back to the motor cortex. This provides negative feedback to control the motor cortex activity. It shows two distinct circuits. First one is the caudate loop, then second one is the putamen loop. Caudate loop, the information coming from the cortex reaches the caudate nucleus, plus globus pallidus interna, then pass reticularis of substantia nigra and then back to the thalamus. Whereas putamen loop, information coming from motor cortex to the putamen, globus pallidus interna, then pass reticularis of substantia nigra and to the thalamus. So the basic difference between caudate loop and putamen loop is involvement of these two nuclei, caudate and putamen. Let's see the functions of these two loops. Caudate loop mainly function is cognitive control of motor activity, that is thinking and planning and eye movements, whereas putamen loop motor control of subconscious body movements, that is automatic movements. If you understand these functional neuronal loops, then the functions of basal ganglia becomes very clear. Here comes the important part of the answer, that is functions of basal ganglia. Basically, basal ganglia shows four important functions: voluntary motor activity, reflex muscular activity, control of muscle tone, and arousal mechanism. Let's see each in detail. Voluntary motor activity. It mainly helps in cognitive control, that is, the discharge begins before the movement. Next is timing and scaling, how rapid and how large the movement should be. And lastly, about the subconscious execution of movements like swinging of arms while walking or clutch brake while driving. Next is the reflex muscular activity. Basal ganglia inhibits spinal reflexes, so it coordinates mainly the posture. The next is control of muscle tone. In control of muscle tone, It controls the muscle spindles, mainly the gamma motor neurons. And in arousal mechanism, globus pallidus links to the reticular formation. The lesion of this mainly produces drowsiness. So basically, basal ganglia release cortex from routine acts so that the cortex can plan some important movements. Look at the clinical features. Parkinson disease or paralysis agitans. It is discovered by James Parkinson in 1817. The etiology include two causes, primary cause and secondary cause. Primary cause include idiopathic degeneration of nigrostriatal dopaminergic neurons, whereas secondary cause include viral encephalitis, cerebral arteriosclerosis, or dopamine blocking drugs. The main pathogenesis is imbalance. There is a loss of dopamine, so that causes imbalance between the excitation and inhibition. So decreased dopaminergic inhibition of putamen ultimately causes a reduction in excitatory drive to the cerebral cortex, and this ultimately leads to inhibition of the direct pathway, so there is a less motor movement, and stimulation of the indirect pathway, so there is a more unwanted movements. If you understand this pathogenesis at the cellular level, you'll realize the different clinical features of Parkinson disease. The symptoms of Parkinson disease becomes easy if you understand one principle. The patient simply cannot move normally. The four classical features are akinesia, hypokinesia, rigidity, tremor, and postural instability. These are frequently remembered using the word trap, that is tremor, rigidity, akinesia, and postural instability. Let's see the each in detail. First, akinesia. So there is a difficulty initiating movement due to hypertonicity and not paralysis. There is a bradykinesia and mask-like face. And the gait is Festolen gait, that is shuffling, bend forward, and short, rapid step. Now rigidity. There is an increased tone in both protagonistic and antagonistic muscle. It shows lead pipe as well as cogwheel type of rigidity. Now the tremors. Here there is a resting tremors of 4 to 6 Hz, classic pill rolling movements of thumb over the fingers, but it disappears during activity and exaggerated by stress. If you ever see a Parkinson's patient during a clinical posting, try identifying these four major signs. You will never forget this topic. Now let's see the treatment of this Parkinson's disease. Let's answer one of the most frequently asked university questions. What is the physiological basis of treatment in Parkinson's disease? Remember, the disease occurs because of dopamine deficiency. So logically, the treatment aims to increase dopamine activity inside the basal ganglia. There are several approaches. The most common is giving levodopa, which crosses the blood-brain barrier and is converted into dopamine inside the brain. Remember, low dose of L-dopa decreases rigidity, whereas high dose decreases tremor. Another option is role of carbidopa. It is administered along with L-dopa. It prevents L-dopa conversion to dopamine in the liver, and it cannot cross the blood-brain barrier. And the third option is surgical management. There is a destruction of globus pallidus or ventrolateral thalamus nucleus to restore output balance. So remember, there are two options, L-dopa and carbidopa. Now, instead of listing drugs randomly, always begin with a physiological principle. Treatment aims to restore dopaminergic activity and rebalance the direct and indirect pathways. Then write the examples. This creates a much stronger university answer. Now let's see the practical exam specific difference between spasticity and rigidity. Actually, both involves hypertonia, but the mechanisms and manifestation they differ fundamentally. Spasticity, the lesion is in pyramidal tract, whereas rigidity it is in the basal ganglia. The muscle involved in spasticity is one group, either agonist or antagonist, whereas in rigidity both are involved. Spasticity is clasp knife type, whereas rigidity is a lead pipe or cogwheel type. Spasticity is stage sensitive, that is velocity matters, whereas rigidity not stage sensitive. Spasticity is velocity dependent, that is a stage sensitive, but rigidity is not. Basically, rigidity is caused by increased discharge of gamma efferent supplying the muscle spindle, and it can be confirmed by 1% Poker injection abolishing gamma discharge and rigidity. Different nuclei produces completely different disorders. That's why examiners love asking this question. So let's simplify each. Basically, other basic nuclei disorders are mainly three: hemibialism, Wilson's disease, and kernicterus. Hemibialism. It is spontaneous flare-like intense movement on opposite side of the body. Lesion is mainly in the subthalamic nucleus. The Wilson's disease. It is due to copper intoxicity because of the low plasma ceruloplasmin. The lesion is lenticular nucleus, mainly putamen. Here it shows the features of liver cirrhosis and Parkinsonism. Kernicterus. It is indirect bilirubin which crosses the blood-brain barrier, especially seen in RH incompatibility in newborn. Religion is in globus pallidus. It shows the features like rigidity, chorea, acidosis, mental deficiency, or death. Other hyperkinetic disorders include chorea, acidosis, and Huntington disease. Chorea is basically rapid, jerky, involuntary dancing movements. The lesion is in caudate nucleus. Acidosis. It is a slow, rhythmic, twisting worm-like writhing movements. The lesion is in putamen. And lastly, the Huntington disease. It is autosomal dominant genetic disorder. The lesion is damage to the GABAergic or cholinergic neurons of stratum. It basically progresses from jerky hands, coriform movements, slurred speech to the dementia. So, in summary, for hyperkinetic disorders, remember loss of GABAergic pathway release inhibition causes hyperkinetic features. Let's revise the entire clinical physiology of basal ganglia by using this ultimate hack of matching the damaged nucleus to the resulting clinical sign. Now, before moving to the table, first understand rule of thumb. That is, a loss of dopamine causes hypokinetic movement, example in Parkinson disease, whereas loss of GABA or inhibition causes hyperkinetic movement, example chorea and embolism. Now let's see each anatomical structure lesion causing the disease or sign. Lesion in substantia nigra, that is pars compacta, produces Parkinson's disease. Lesion in caudate nucleus causes chorea. Lesion in putamen causes acidosis. Lesion in stratum produces Huntington disease. Lesion in subthalamic nucleus causes hemiballism. The accumulation of bilirubin in globus pallidus produces kernicterus. And lastly, the copper accumulation in lenticular nucleus produces Wilson's disease. Now memorize this table right before walking into the exam hall. If you understand this one flow chart, almost the entire physiology of basal ganglia becomes easy. Now let's focus on the examiner's perspective of the complete answer. This is the final 10 marks answer structure that the examiner appreciates. Start with definition, components, then about the nomenclature of basal ganglia nuclei, then connections and wiring of basal ganglia, the direct pathway, about the indirect pathway, then about the different functional neuronal loops including caudate loop, putamen loop, then the physiology or functions of the basal ganglia, the Parkinson's disease, the clinical features, the different hyperkinetic disorders, and the other basal ganglia disorders. And finally, conclude with this table showing the different lesions, anatomical structure, and the resulting diseases or sign. Remember, always use underline headings, flowchart, neat diagrams, comparison tables, and bullet points. This not only improves readability, but also helps the examiner to avoid mark quickly. Would you rather read 5 pages of plain text or one beautifully organized answer? The examiner thinks exactly the same way. If this video helped you understand basal ganglia and how to write a perfect 10 marks university answer, don't stop here. To strengthen your preparation, watch the complete learning series, rapid revision video, revise the entire chapter in just 5 minutes before your exam, and the memory videos, learn the direct, indirect pathways, dopamine, Parkinson's disease, and basal ganglia lesion using simple flowchart and memory trick that you will remember during the exam. If you found this lecture useful, like the video, comment below which physiology topic you like the most, and share it with your MBBS classmate. And don't forget to subscribe Physio with Neo. Here, every physiology topic follows one simple formula: learn, revise, and remember. Until the next lecture, keep studying smart and stay consistent. I will see you in the next video.